Amit, please, the floor is yours.
All right. Well, thank you, David. Thank you, Fran. Good morning, and thank you to the Match Coalition for having me at your monthly meeting. My name is Amit Trivedi. I'm the Senior Director for Informatics and Health IT Standards at HIMSS. And in my role, I help support the community of standards developers and implementers in the US and around the world. And so I work in informatics and health IT standards. I've spent many years in certification, testing, compliance, from ethical hacking and network security to EHR, medical device, and app testing. And now I support our work at HIMSS in committees like IHE International, HL7 International, and projects with many different three-letter acronym agencies from ONC, CMS, CDC, FDA, WHO, etc. And so I get to work with some amazing people across the world, and that hopefully provides a little bit of the context and background around some of the information that I'll be sharing with you today. And so I'm excited to talk a little bit more about the importance of health data privacy and how it relates to maternal health care, and the broader concept of equitable interoperability. I'm always excited to talk about maternal and child health care because there's always an additional focus on the patients. We have to focus on care. We have to consider many different complicated use cases because they all present themselves eventually. And when we do discover breakthroughs, when we manage to implement a good solution or create improvements, guess what? More often than not, those improvements result in benefits for everybody. Also, I have some personal and professional interest here. I'm a dad of 3 boys. That alone should tell you that I'm not an expert because I only meant to have 2. But that said, I'm married to a brilliant woman and a mother. I'm the son of a brilliant woman and a mother. And so I've had the benefit of many opportunities to learn. And so I'm here today as an ally and to try to do my part to learn, to help where I can. And I think we all know that not enough has been done in this space. And, this space, especially where I work in standards, has often been dominated by men. And so we see those disparities in care and in the resultant policies, the technologies, the workflow. So suffice to say, there's a lot of work to be done in this space, and but we're excited to do it. And so beyond all of that, we know the U.S. is facing a maternal mortality crisis, particularly to women of color. We've seen the stats from the CDC. Black and Indigenous women are 2 to 3 times more likely to experience worse maternal health outcomes. And then on top of it all, the COVID pandemic has put even more strain on all the resources and systems and made inequities, even worse. And so where are we today? Well, we live in an on-demand, cloud-based, instant gratification world. Well, some of us. We live in a world of haves and have-nots. And so this is especially true when it comes to healthcare and health IT. And so for context, we have the 21st Century Cures Act, which has really gone all in on interoperability after a decade of health IT incentives in billions of dollars to help adopt certified health IT. Unfortunately, most of these benefits haven't quite trickled down to what's basically a patchwork of public and private organizations that help support prenatal care, social services, and more for pregnant and postpartum women, and especially women with low incomes. And the lack of support for these services only, again, additionally increases some of that health inequity. And so while the government is all for data sharing and even going as far as to penalize the class of actors that they term as information blockers, at the same time, we're creating exceptions to allow information blocking or to permit it in some cases. And those cases are to prevent harm to a patient or a person. Information can be blocked if it's deemed necessary to protect an individual's privacy or to protect the security of electronic health information, or when the request is infeasible. And so we know we live in a world with complex technology and policy considerations, but if we don't address some of these issues, they can become excuses to allow information blocking and excuses to permit these inequities to continue to exist. And so as we're kind of digging into this world of haves and have-nots, let's see let's consider electronic health data, the data that's in the electronic health record, in your chart, in the mom's chart, how and when that data can be useful, helpful, of vital importance, and then also those cases when some of that data is deemed sensitive, and when it may make sense to withhold or redact that data, and what those repercussions of those actions are. And so there's a lot of information that can be stored in a mother's prenatal record, and that impacts a newborn's care. And some of that information makes its way into that baby's chart as well. And so what kind of data is considered sensitive? Well, let's start with registration and demographic data. That can also consist of sexual orientation, gender identity, consent to treat for sensitive procedures. That data can be stored in PDF format, in vendor-specific structured data. How that data is stored also impacts how easily that data can be shared or not. Other types of data include patient-level data like the problem list, med list, allergies, often stored in granular form, SNOMED or RxStorm terminologies. Then we have things like our social history, and even more becoming a bigger part of the conversation today is collecting social determinants of health data. And so now here we'll see in some cases vendor-specific structured data, but more often than not unstructured data, which also consists of very sensitive data, especially when we start to look at social determinants of health that could and social histories. That could include intimate partner violence, postnatal depression, even more. And so some of this information is documented so other providers can understand any concern to a patient's safety. We also know how much social determinants of health can impact outcomes. So there's a huge drive to collect this information, but are we doing the right things to make sure that that information is stored? And we'll talk about that in just a little bit more. But finally, additional data that can be stored in the patient record includes episode-level data. That can include the visit note, individual sections of a note, often unstructured. It could include procedure documentation, again, sometimes unstructured, sometimes that includes PDFs, images. There's often screening questionnaires, which can be also sometimes vendor-specific and structured, sometimes not. Diagnostic tests and results. And where does all this data go? Ancillary services, other providers, the patient portal, printed reports, third-party apps, health information exchanges, state departments of public health, ACOs, payers. So this is in an ideal world where interoperability is happening and all this data is being exchanged. But this also increases the different types of privacy concerns. So for example, take the patient portal. In a patient portal, and especially when you're considering a newborn or a child's patient record, a husband or a partner can be a proxy. Typically, an EHR has the capability and functionality to hide certain information like notes or problems, but not all the information, especially things like appointments, which can reveal certain sensitive information. There are additional privacy concerns that can arise through the interoperability working with payers. So again, insurance, often through a spouse's employer. EOBs, explanations of benefits can be mailed to the family address, which can inadvertently expose sensitive privacy information, private information. When information is sent to other providers, they may not have the context to understand when or how to hide or redact problems. When information goes to pharmacies or ancillary services, the resultant actions can result in text messages, reminders, other types of information disclosure that may be inadvertent. And then finally, in the shared patient record, when this infant becomes 18 or older, that data from the mom's record is also exposed. And so today, this has become an increasingly bigger and bigger challenge. We have more and more stakeholders. We have many more different types and flows of data, both internal and external. The question of data ownership remains unresolved. There's access control definitions in every organization. There are questions around patient safety versus the right to individual privacy. And ultimately, the development and implementation of the standards to support all of this is very complicated. And so this leaves us with a too big to solve or too big to tackle issue. And because this problem has been difficult, we kick the can. And so over the years, we pick the low-hanging fruit, we go for the immediate ROI, and here's where we are. We have a state where the exchange of information is of vital importance. We do not have the capabilities to protect privacy at the granular level. And so, and I mentioned at the granular level, and I talked about the types and formats sensitive data is stored in. And so when organizations are faced with having to exchange information in the face of potentially exposing sensitive privacy information, many organizations wind up blunting the privacy protections to comply with state laws, and then often fall back to an all or none position around sharing data. And so that leaves us in a place where folks with sensitive data in their electronic health record are in a position where their information is not being shared. And so there's a case that the folks who need the most interoperability services that could benefit from the shared information in their health record are not receiving it. And so that, in a nutshell, is describing some of the inequities around interoperability when privacy is not addressed. And so to continue the conversation, there has been a lot of activity in this space. There have been billions of dollars around health IT certification, a lot of standards developed and supported. However, various efforts that have come forth have lagged. Two big ones around privacy and consent are data segmentation for privacy, DSVP, and consent to share. And while progress is made, adoption has lagged, and there's a number of reasons for that. One, it's hard to meet a number of high priority clinical use cases across the spectrum instead of solving for one or two specific. Implementation is not easily scalable across these organizations. There's still issues related to patient safety and usability that aren't adequately addressed by pilots, and it's always difficult to have more pilots. And then finally, there's a lack of financial or regulatory stimulus to support or incentives to support this activity. And so a lot of the groups that I work with are focused in these areas to help advance the state of the art of the possible around privacy protection and granular protection of privacy. And so what can we do as a community to help advance and support this work? Well, one, we can support groups like the Match Coalition and learn more about complementary activities. You can participate in HIMSS communities, whether it's the policy community, interop and HIE community or more. And then you can also get engaged in other groups. And one I can mention is the Protecting Privacy to Promote Interoperability, PP2PI work group. Those of us in health information technology, we're not always the best at marketing, and so we're always working on better names, and the PP2PI group is working on a better one as well. But this group in particular is a national multidisciplinary interest group of experts from across the industry, and we're really working on the specific focus of how to address the granular segmentation of sensitive data to protect privacy and promote interoperability and care equity. We've been also working together through this digital series we've created within IHE USA, and that's iheusa.org. It is another nonprofit standards organization supporting the profiling and implementation of IHE and other world-class standards in the US. IHE USA has developed a digital series called The Path to Production, and it's really focused on supporting the advancement of implementation. I talked about so many challenges to implementation. Chief among them are getting folks' attention for all the competing projects and activities that are going on. And then providing a venue for folks to reconvene, and make continuous progress. So this Path to Production series by IHE USA, the concept around that is to convene diverse stakeholders, because the folks we were convening 10 years ago, the composition has changed. We're focusing on the art of the possible, accelerating production-level interoperable health exchange. And our next events are actually tomorrow, June 22nd and 23rd. We have events every 2 months. They're free. You can register at iheusa.org and find out a little bit more about specific projects like PP2PI, like the different activities that are happening within the HL7 fire accelerators, ONC projects, and more. And so hope you can join us there. And so with that, I think I'm about at time, and so I will conclude my presentation and pass it on for questions and next steps. So thank you very much.
Great. Thank you so much, Amit. Does anyone have any questions? I know we covered a lot, and we can also share his email in the chat if anyone wants to have any offline conversations with him. So any questions? Great. Well, Amit, thank you so much for joining us. I'm sure we'd love to have you back in the future, especially as the Path to Production series continues its great work. So with that, Fran, I will pass it on back to you.
Thank you so much, David. Just we're really excited to be transitioning. Thank you, Amit. That was amazing information regarding the work that is being done on privacy and security. And as you pointed out, increasingly, there is more and more information about women, not only about their clinical information, but also about their social, more private information that is painting what we like to call in the IEC the digital twin, if you will. And so what does that mean and what impact that has on women is something that we certainly should spend some time discovering and talking more about. So thank you for that very informative presentation. We've now reached a point in the program that I am so honored to be able to help moderate. I am really thrilled to be able to introduce to you two very distinguished individuals, Dr. Gloria Bachmann, who is a professor of obstetrics and gynecology in medicine. She is also the Associate Dean for Women's Health, the co-director of the Women's Health Institute, the medical director of the Proud Gender Center of New Jersey. She's the medical director of the New Jersey Commission on Women's Reentry and the chair of the Health Committee, and very much engaged very actively within her positions with at Rutgers Robert Wood Johnson Medical School. We are also very honored to be joined by Dr. Pamela Brug, who is an obstetrician gynecologist with Rutgers Robert Wood Johnson Medical School, as well as faculty with Hackensack Meridian Health, Raritan Bay Medical Center, and the Hackensack University Medical Center. She's also the vice president of the New Jersey Black Women Physicians Association. Ladies, thank you so much for taking time out to meet with us today. Our focus is on the state of New Jersey. I couldn't have thought of two better people to come and speak with us today about the state of New Jersey, and we're really honored to have you. We're going to jump right in because there's so much that we want to learn from you, and we want to also make time for our participants to be able to have time to dialogue and ask questions. So why don't we get started? New Jersey was selected as one of the states to be an area of focus for the Match Coalition this year because it is unfortunately within the top 10 in terms of maternal mortality, morbidity. I'd like, if you don't mind, to maybe kick us off. And Gloria, if you don't mind starting, and then Pam adding to it, describe for us a little bit about the state of this. What does it mean? We say mortality and morbidity, there's a lot to that. Can you just kind of describe some of those dynamics? Is it the same across all of the state? Are there certain pockets that are more challenged? Tell us what's really, going on. What is it like within the state of New Jersey?
Well, first, let me begin by saying that Pam and I work together on this topic, as well as many other topics. And you mentioned one that we're also very involved in, and that's the reentry program for New Jersey women who are incarcerated and then reenter their communities, and the hurdles that these women also have from both a pregnancy stance as well as an overall wellness stance. And we also work with my co-director of the Women's Health Institute, Dr. Juana Hutchinson-Colas, who is also very involved in these initiatives of improving the health care of all women, especially Black women, and the increased morbidity and mortality that Black moms do have, that the data show very clearly are basically overrepresented in morbidity and mortality statistics. And I think one of the issues, and I'm going to hand it over to Pam, that we really have to keep in mind is the social determinants of health, which is now what it's been termed. And what that means is that if I'm pregnant and have no place to live, I have food insecurity, I may be in a situation where I'm caring for elderly parents and can't really leave the home to go for healthcare visits. I may have young children that need care. I may have a special needs child that needs special care. And if I'm pregnant, there are going to be so many obstacles to my getting good care, good prenatal care, just from the social determinants of health, versus if I were living in a community with a stable home and adequate food. And if I had to leave young children, I'd have other relatives or friends to take care of them, and so forth and so on. So I think that is one of the issues that we have to address, and also some of the barriers, some of the issues of what information is getting to the women of every community. And I think that Dr. Brug can speak to that, especially on the COVID, that she was very involved with the COVID testing, the COVID vaccination. So I'm going to turn it over to Pam just to give a little bit about all the community outreach that she has done for the New Jersey Black Women Physicians Association.
Hey, thank you for having me. But I think what we need to start off with understanding that New Jersey, as being one of the richest states, is 47th in maternal health outcomes. And that's unacceptable. And the reason that they're 47th is because there are poor maternal outcomes for Black pregnant persons, including morbidity and mortality. So in New Jersey, a Black pregnant person, it has a risk 7 times greater than their white counterpart in dying surrounding their pregnancy, which, as we know, can be up to a year of having a delivery. So I think it's important to understand that environment. And even though we are one of the richest states, there are certain places, including our capital, Trenton, which are basically deserts, right? There are no OBGYNs, there are no clinics that can actually take care of the pregnant persons in that area. So you want to take all of that into consideration when you then discuss about initiatives, understanding the data. And one other important aspect of it is always remember that these numbers exist across socioeconomic lines. And 60% of them of the reasons that pregnant persons die within a year are preventable. So I think that's very important to understand.
Let's talk a little bit about that.
Let me just go through that. This Dr. Brug brought up one important point, and that is, which has been looked at very carefully, and it exists, is that number one, the complaints are often minimized, or they're not heard at all, or the encounter when the individual goes into a healthcare setting is less than optimal. And I think we saw this with some and Dr. Brug brought this up, with some individuals who are tennis stars. Everyone knows Serena Williams' name, who was not believed. So that there is also the actual encounter where, is it an optimal encounter? Is the healthcare provider listening? Is the healthcare provider giving accurate information and feedback? Is the correct care being given? Is the correct testing being given? What was, the next follow-up appointment? Was the person said, oh, just go home and, goodbye, versus let me see you in 24 hours, but if the headache gets worse, come right back. So I think we have to look at the actual encounter as well, because many times it's not an optimal encounter, a healthcare encounter.
Yeah, I think you have to take into consideration, and we know this in the state, is the implicit bias or overt racism that does exist in the medical field that has an impact on these this data that we're all discussing right now. And so that is one of the major issues. As an association, we actually have an initiative that says Believe Black Women, because of those types of encounters, as Dr. Bachmann has described.
Let me just follow through on that, we will hear that a woman will be sent home with a severe headache and no one checks her for eclampsia. So her what she said was not taken seriously, was not believed. And I think that truly is an issue that has to be brought to the forefront.
Thank you for sharing that. So the CDC has a program referred to as Hear Her. It's a national program that looks at, encourages folks to recognize first the individual, but as well as family and partners and clinicians to observe and take and to respond appropriately when it comes to signs and symptoms and symptoms that an individual might be complaining about. How is that showing up within the state of New Jersey? What programs are being implemented that are addressing some of the preventable causes?
Well, I'm going to have Dr. Brooks go into some of the details, but let me give you a global view. We recognize this issue and really commenced the Stop, Look, and Listen campaign, which is the same as the CDC Hear Me campaign, although we really did it first because we saw the problems and we said there has to be the healthcare provider has to stop when a woman says she's having a problem, look at her, examine, make sure there's no edema, the blood pressure is not high, etc., and listen, totally listen to the entire encounter. So the Stop, Look, and Listen campaign really started in New Jersey for the same reasons that Dr. Brug said, because of the implicit bias, etc., that you have to take the woman or take the individual, because trans men do get pregnant. So take what the individual is saying, stop, look, and listen. And I think the other thing that New Jersey has done, well, there's actually two other initiatives. The first is we were the first to start Maternal Health Awareness Day, which is also really becoming a more national holiday. It was adopted by the American College of Obstetricians and Gynecologists, and it basically is the same focus: stop, look, and listen. And our First Lady, Tammy Murphy, that Dr. Brug works very closely with, has started the Nurture New Jersey initiative, which again addresses the issues that we're talking about, and that is really key because it has a lot of legislative initiatives in it. And I don't know if you wanted to take over some of talking about that, Pam.
Yeah, so I think in New Jersey, we've made some steps forward. One of the things that has been done, there's a maternity quality collaborative that has been set up, which encompasses all from public to private sector to community-based organizations to payers and legislatives in regards to what is actually occurring in New Jersey and some of the steps that we can use to address it. New Jersey is also broken up into 3 perinatal consortiums, and within those consortiums, there are associated hospitals. Most hospital systems have now set up protocols in regards to the most common reason that a pregnant person dies in New Jersey was postpartum hemorrhage, which is thought to be preventable. And most hospitals now have set up protocols. The identification and the symptoms and signs of preeclampsia and of infection and sepsis, which are also major causes of surrounding morbidity and mortality in New Jersey. So those are some of the things that have been done. But a big thing that has been done, at least for the Medicaid population, which we're working to do it for all payers, is the coverage of community doulas. So a non-clinical person to be the voice of the pregnant person and their families during sometimes can be a stressful situation, and being there to help advocate for them. We are cognizant that if you look in health systems, that especially a Black male, security is called on them faster. And so therefore their voice can be tempered, right, for advocating for their partner. And so a doula can step in and be that voice to advocate and to protect the pregnant person and her family.
These are all amazing initiatives. I also understand that First Lady Murphy also has initiatives that are centered around the use of technology, digital technologies. Could you share a little light on us on how you see the role of technology playing, assisting and sort of addressing some of these preventative areas?
Well, I think in regards to technology, one is that the data. We are trying in New Jersey to have a full data bank in order to better gear what our next initiatives are and what our next policies may be. And so that's very important that we have good and correct data. The other things are there are maternal echoes, which is a platform where there's actually educational forums that are done for providers. And we actually just did one, which was for the public on COVID vaccinations. Because of the disparity that existed in regards to getting Black and brown pregnant persons vaccinated, but they were actually having higher morbidity and mortality from COVID infections. So I think that's one. I think that we have a joint research collaborative with the Women's Health Institute, where we have younger learners from undergraduate students all the way up to residents who are looking at some of these issues and addressing them, and to see how we can use technology to further the and improve the outcomes that we are seeing in New Jersey.
And I think one of the major areas that we could immediately think about is monitoring of vital signs that technology can really be instrumental in. So that if I, Gloria Bachmann, am 32 weeks pregnant and I don't feel well, and I take my blood pressure and my blood pressure is 190 over 140, and that goes into a central repository, that's a red flag that I have to immediately get to a medical center to get care. That I cannot wait for an appointment the next day, or wait until, maybe I'll feel a little better after I have dinner. That technology can really be the alert for a woman or an individual who is having a problem, or you could see the progression of the problem. So that if my blood pressure starts at 120 over 80 and then it starts going down, and I say, well, I'm having a little bleeding. Well, I may be having a lot of bleeding and I'm becoming hypotensive. So again, technology that we can monitor the individual so that we can see the warning signs that there's something that's going on that's not right is really key to really stepping in and making a difference in the morbidity and mortality, not only for the pregnant individual, but for the baby or the babies that are being carried by that pregnant individual. So technology is clearly very important. But I think the other aspect that we have to bring up, for instance, if this is a telehealth visit, does everyone have the resources for telehealth? So that's the first thing, is do we have the resources in a community to give everyone the opportunity to have telehealth? The second is, do I have privacy? So that if I had others living with me, that I had some information that I did not want to share, that I was HIV positive or something, that I don't have privacy in a telehealth visit in an open forum. So, there are obstacles to technology that we also have to address to make sure that we really can implement them in a way that is beneficial to the individual and not harmful. So that if I, in a telehealth visit with everyone involved in my family, relatives, and so forth, heard things that I did not want them to hear, that may actually make my home environment more hostile to me, and it will actually have a negative impact on my overall health, on my pregnancy, on my delivery. So again, it really is key to have the resources and to make sure that those resources can be used in a safe setting.
Mm-hmm.
I love that you point that out. Environmental awareness is so important, as is having access to the technology. These are all excellent points. I'm just going to remind everyone, we're about to move into the Q&A session in just a moment here. So if you have any questions, we're looking forward to hearing those from you. Before we get there, the other side of the technology end, while we recognize that there are challenges and opportunities that exist for individuals, for the expectant mom, but what about on the clinical side, how do you see the readiness taking place within the clinical environment? I know we have witnessed with COVID, there was, an increased utilization of telehealth technology, but it really only represented about 30% of overall practices. Can you talk to us about sort of what you see as being the vision within the state of New Jersey around adoption of digital technologies amongst clinicians and their educational readiness, their digital literacy?
Yeah, I think that one of the things that we have to consider is where are those practices or clinics located, right? And how are they actually being funded? Right? Because one of the problems, especially in older practices, they did not have electronic EMRs. They were still using paper. And I think that's one of the things that we do have to work better at. And it's one of the things that's being done in regards to the adoption of electronic medical records to help facilitate. But at the same time, looking and seeing, well, how can you? Is there a grant? Is there funding? What can we do in the state to make that affordable for especially your primary care physicians who are solo practitioners? I think that's one of the things that we definitely still need to address appropriately.
Yeah, and I just want to expand on that is one of the areas that we're addressing right now in the Barnabas system, where we're going to an EPIC format, which is electronic medical record, such that if I'm taking care of an individual who has other issues, medical issues, that I can address them in my decision making so that it's more comprehensive. And these are all HIPAA compliant, which we talked about earlier, the privacy, that I don't want my information, my health information, known to everyone, but to those who need the information. And basically, not only is that information accessible, but it also shows if Gloria Bachmann accessed that medical record, so that if I looked into Pam Brug's medical record and I had no reason to do that, that would show that I was looking into medical records that I should not be looking into. So I think the technology is very good, and it also keeps it HIPAA compliant, and that the practices that had been on paper, such that the information could not be shared. So when the individual came to the hospital, we had no idea that the blood pressure was running, 90 over 60, and now it's 120 over 90. It's much higher. That because of the records that were on paper rather than electronic, that we had no access to. So this really is a major move forward, getting the electronic medical record to be a universal one that can be shared, so the best care can be given in a HIPAA compliant manner.
And I think because New Jersey's the two largest health systems in New Jersey are now both on Epic, I think that helps, because you are now sharing information, as we said, HIPAA compliant, but allows you to note if someone went to another hospital for et cetera, and take that all into consideration. And as more and more systems are coming onto this one system, it will help in regards to sharing of healthcare information.
All outstanding points. And I think it, can't be stressed enough that, the adoption of EHR was a challenging experience for many practitioners. We saw some early retirement of some phenomenal physicians as a result of the way in which they were introduced to the technology. We certainly don't want to see that happen with others when it comes to the adoption of digital technology. I think in desperation, many embraced it and found that it was, wow, it was kind of like, I always call it their Sam I Am moment. They tried the green eggs and ham and they actually loved it. So perhaps if there's, ways or methods by which we can get more to begin to try and to create for safe environments in which they can gain their confidence in the technology, but also, as you both have described, create those reassurances around how the data will be managed and shareable is certainly very important. We're coming close to time. This has been so amazing. I wish we had like another 15 minutes, to be honest, but we don't. We have to be respectful of everyone's time here today. We will take at least one question from the participants. If anyone would like to ask a question, now is a great time. Any questions? All right, I'm going to bring to bear one. Early on, you talked about a reentry program and incarcerated women, and this is an area where we've heard horror stories of women who've given birth in cells, who were unassisted, unattended to during labor and delivery in various states. What do you have much information, or perhaps give us some guidance on what the dialogue is right now around incarcerated women and how technology can perhaps be used to support them and their needs?
I think it has to be recognized first, the needs of incarcerated women and those who are recently re-entered, and there has to be legislative backing. And I'm very proud to say that the New Jersey Reentry Program is actually on the forefront of ensuring that all individuals who are incarcerated do get the best care, especially those who are expecting, who are pregnant. So the New Jersey Reentry Program is one that is looking at everything that you've just talked about. What's the best technology to use to optimize the services.
Wow, that's amazing. Well, thank you both so much. I hope you'll be open to others reaching out for you as there are many who would like to be involved in activities that are going on in the state of New Jersey. We can't, again, thank you enough for your time today. And thank you to everyone for joining us. We'll see you again next month in July, always the third Tuesday of the month. Until then, take care, everybody.
Bye-bye. Thank you for having me.
Bye-bye.
Thank you, everyone.